and mask. Cover all injured or exposed wounds or cuts with a bandage before proceeding for sample collection. Determine the best site for venipuncture. The common sites are antecubital area. Median cubital vein is the most preferred site as it is large, well anchored, least painful, and least likely to bruise. Cephalic vein is the next preferred site. It is large but not well anchored and may be more painful than the median cubital vein. The basilic vein is the third choice. It is generally large, easy to palpate, but not well anchored. It involves the greatest risk as it lies near brachial artery and the median nerve. Either of each can be easily punctured. Dorsum of the hand. The veins on the dorsum of the hand have a greater tendency to bleed. In fat persons, however, it may be difficult to access an antecubital vein. In them, the veins in the dorsum of the hand are easier to reach. Alternate sites. Phlebotomists will not collect blood except under special circumstances from the arm or hand from the side of a mastectomy, unless all other sites have been ruled out, and only with written permission from the physician or nurse. Limbs with indwelling artificial access devices, unless all other sites have been ruled out and written permission of the primary care physician. Unacceptable sites. Phlebotomists will not collect from fistulas, shunts, arterial lines or locks, arteries, femoral vein, varicose veins, and the palmar region of the wrist. Venipuncture. Venipuncture procedure includes labeling of tubes, which may be done prior to or immediately after collection as per the policy of the institution. The label should be clearly written with at least 3 patient identities like age, name, unique ID number. After the patient is made comfortable and seated on a chair, ensure proper positioning of the patient's arm. Apply the tourniquet with 3-inch clearance above the planned puncture site. Ideally, the tourniquet should not be applied for longer than 1 minute at a time. Note: leaving the tourniquet applied for an excessive period of time, that is, more than 1 minute, may cause localized stasis, formation of a partial filtrate of blood, and hemoconcentration. These may result in erroneously high values for all protein-based analytes like packed cell volume and other cellular elements. For coagulation studies, avoid using tourniquet or apply it for less than 1 minute, as platelet activation may lead to coagulation testing errors. Clean the venipuncture site with 70% isopropyl alcohol swabs or sterile swab using a circular motion from the center to the periphery. Never do the reverse. Allow the area to dry before venipuncture. The puncture will be painful if alcohol has not dried. Hemolysis is also a possibility if alcohol gets into the sample. Do not repalpate the venipuncture site once it has been cleansed with alcohol. Alert the patient before venipuncture. Ask the patient to close their fist, but do not allow the patient to pump or clench their fist. Tell them to relax. Make sure that the patient's arm is in downward position to prevent the backflow or reflux. Anchor the vein and smoothly insert the needle with bevel up at 15 to 30-degree angle. In case of difficulty in location of vein, phlebotomist must tell patient about the same. Lab should have a policy to record multiple punctures. Multiple punctures can decrease patient confidence and satisfaction. A clean, sterile needle must be used for each new collection attempt. Never re-prick a patient using the same needle. Release the tourniquet as soon as blood begins to flow. Avoid excessive negative pressure. No attempt should be made to withdraw blood faster than the vein is filling. This will lead to insufficient quantity of sample, hemolysis, and contributes to vein and patient trauma. Needle removal. The tourniquet must be fully released and patient's hand opened and relaxed before the needle is removed. Hold dry cotton or gauze pack over the site. Gently and quickly remove the needle from the arm, and as soon as the needle is removed, pressure must be applied to the site to avoid leakage of blood and hematoma formation. Ask the patient to keep slight pressure on the cotton. The arm is to be kept straight and not bent at the elbow. Instruct the patient to discard the blood-stained swab in yellow bag before leaving. Provide the relevant information in case the patient asks the phlebotomist. Delivering the blood. Deliver carefully into respective tubes as per requirement for test ordered and in proper order, which shall be discussed shortly. Vacuum extraction system. When using evacuated system where blood directly flows into the tubes, ensure that the tubes are kept in place till the blood flow completely stops by exhaustion or vacuum. Place the next tube as per the order of draw till all the required sample tubes are completed. This would ensure collection of appropriate volume of blood without the need to open the cap. When using syringe and needle with evacuated tubes, opening the cap of an evacuated tube increases the risk of compromising the integrity of the primary sample. If a syringe is used, it is recommended to place the tube into a rack before filling the tube. To prevent needle stick injuries, use one hand technique to puncture the tubes with the needle to fill the tube under vacuum. Pierce the stopper on the tube with the needle directly above the tube using slow, steady pressure. Do not press the syringe plunger because additional pressure increases the risk of hemolysis. When using syringe and needle with non-evacuated tubes, first remove and discard the needle in sharps container. Now transfer the blood into the non-vacuum tubes. Remove the cap of the container and gently transfer specimen into it by pushing the plunger. Blood should be allowed to smoothly flow from the side of the walls of the tube while ensuring that there is no froth formation during the transfer process. Phlebotomists should never push the plunger too hard in order to avoid froth formation or hemolysis and the risk of aerosol formation. Immediately after collection, invert gently the tubes containing additives for the required number of times as specified by the manufacturer. Do not shake the tube. Do not overfill the tubes. Blood culture sample is to be collected first and the sample is transferred into the blood culture bottle using a syringe or a direct transfer mechanism as shown in the picture. Order of draw. Refer to this chart for proper order of draw when using a closed blood collection system. The first to be collected is the blood culture bottle and should be inverted 8 to 10 times. Second is the coagulation tube with sodium citrate to be inverted 3 to 5 times. Third is the clot activator to be inverted 4 to 5 times. Fourth is the serum separator tube with no additive. Fifth is the sodium heparin tube, which should be inverted 8 to 10 times. Sixth is the EDTA purple top tube. Seventh is the oxalate or fluoride tube requiring 8 to 10 inversions. Last is the ESR tube requiring 8 to 10 inversions. Standard precautions at sample collection. Assume all patients are potentially infectious. Practice effective hand hygiene procedures. Wear gloves during the procedure and the use of lab coats, masks, and other personal protective equipment wherever indicated. Wear closed-toed shoes or boots. Follow safe collection practices. Have knowledge of spill management. Get immunization, for example, the hepatitis B vaccination. Avoid contaminated equipment by doing routine and proper decontamination of surfaces and instruments. Practice proper disposal of sharps and infectious waste. Keep safety boxes at arm's length. The biomedical waste management. The sharps container must be within arm's reach and clearly visible to ensure safe disposal of sharps. The instructions for appropriate use and disposal can be displayed in the form of flow charts on the working station. Burn the needle and cut the hub of the syringe using the needle destroyer. Perform the following steps. Insert the needle in the needle slot. Push it gently downwards till arcing stops. Put the syringe in the syringe slot. Push the handle of the cutting blade to cut the syringe at the nozzle. The used syringes must be put in 1% sodium hypochlorite solution before disposal. All blood-stained cotton, bandages, etc. goes into yellow bags. All infected recyclable plastics like tubes, gloves, IV infusion line, catheter, etc. go into red bags. The segregation at source of biomedical waste is to be done as per local guidelines. Never disassemble an exposed used needle with your bare hands. Recapping of the needle is not recommended. If recapping of a needle is unavoidable, use the one-hand scoop technique to cover the sharp end of the needle and thus to safely remove the needle from the holder. One-hand scoop technique. Leave the needle cap on the surface and guide the tip of the used needle tip into it using only one hand. Place the needle cap against a firm upright surface with its opening towards the phlebotomist and place the used needle tip into it. Lift the needle vertically and once the tip is covered, use the other hand to fix the cap into place. Clean the surface with disinfectant afterwards to avoid leaving any drop of blood. Prevention and management of needle stick injury. The single most important measure to prevent needle stick injury is do not recap the needles. Destroy needle in a needle destroyer and use a puncture-proof container for used needles. Keep the container close to hand to avoid injury. It is equally important to use proper protective clothing such as gloves. In case of needle stick injury, follow the protocol laid down by the laboratory, which is written and displayed in the collection area.